Hi, welcome to part two of the paediatric assessment. And in this part, we'll be talking about the hands-off assessment and the paediatric triangle. So, what do we mean by hands-off assessment? This is basically when you come into the room or when you see your patient for the first time. With a paediatric patient, it's really important to gain their trust. So, what we don't want you to do is we don't want you to go booming over to the patient and be like, let me take your pulse. You've got to earn the trust. You've got to take in lots of clues before you even talk to them. Don't forget, these tiny patients quite often can't talk back to you. So you're relying on eyewitness accounts. And as you know, secondhand information is not always reliable. That's seen through different viewpoints. So it's time for you to look at the patient and take on board what's there to be seen. So first thing I want to say is that when you're assessing a pediatric patient, don't tower over them. Try if you can to get down to their level. So you need to build up trust and you need to not be intimidating. So if they take a dislike to you, you might need that your crewmate takes over for you and starts to ask questions. You can build trust by sometimes asking about their toys, their teddy, their mum, what their name is, things like that. So get on their level. That means take a little kneel down or whatever. Don't come close to them. So let's go back to the hands-off assessment. What can you see when you enter the room? What you're going to be looking at, you'll take a general overview of the environment. This is what strikes you, first of all, when you walk into places. Sometimes before you even see the patient, you can hear them, you can smell aromas in the room, you can smell clues, you can hear clues, you can see clues. Coming on in, looking at the patient from afar, don't touch them. Hi, introduce yourself. Hi, my name's Gemma. What's your name? Or, oh, who's that there? Or, oh, where's your mummy? Or, anything at all to try and get the patient to talk. If the patient doesn't talk, we can talk to the caregiver. No problem. But if you do get the patient to talk, then it's a real bonus for you because you can tick off airway immediately. You walk into a room, you're looking for your baby patient, you hear, wah! All right, fantastic. Baby's got an open airway, baby's breathing because it's crying. Kid says to you, oh, hi, my name is whatever. They've got an open airway, a patent airway. They're breathing, they're talking, they're conscious. That's a great thing. You've already noticed that. So after airway, we're moving down to breathing again, as per usual. I'm not going to stand here, right, young man, and count his respirate. No. What I'm going to do is just look at him from across the room or her, and I'm going to watch the chest rise and fall. I'm going to see, does that look like a normal respiratory rate? This is why it's good to know. Remember from the last session, normal respirate for a newborn is 44. Annoys me so much. So an adult, as we know, is 12 to 20. So when I go into an adult, a patient, I would look at them and think, does that look like their respirate is between 12 and 20? Yes, fine. No, it's too slow. No, it's too fast. I don't need to know exactly. I just need to know, is it around about normal what I'd expect for this patient, whether it's an adult or a pediatric. So this is where it's important to know your normal ranges. All right, looking at the respirate, I want to see as well, is there any difficulty? Is it taking a lot of effort to breathe? Now, how would I know that from a pediatric? How would I know if it's taking a lot of effort to breathe? Well, noises and what I can see as well. If you see the patient, obviously, taking big, deep breaths in, you see their nose flaring as a mouth breather. You know they're struggling to get that air in. If they're breathing really fast, they might be red in the face. You can see that it's taken additional effort. What can I hear? Normal breath sounds, maybe? Fantastic. You might hear different sounds. I need you to get familiar with these sounds. So, the worst ones, I don't like stridor. I don't like to hear a stridor. What a stridor is, hopefully you'll know this from your asthma and respiratory sessions. A stridor is an inspiratory noise from an upper airway. So it's normally some type of occlusion, whether that's a foreign body occlusion or whether it's swelling, for example, epiglottitis or croup. You'll hear croup a lot. Inspiratory, kind of a steel bark. So let me try and do an impression of it. Hope that didn't wreck your ears too much. All right, so inspiratory, it means that when they're breathing in, the airway is closing up. This is not a good sign. We do not want across the room to hear that. If we do hear that, we're thinking airways in trouble, kids in trouble. The wheeze, the audible wheeze from across the room. I mean, fair play if you go up and you have a stethoscope and you hear a wheeze, that's bad enough. But an audible wheeze from across the room, no, we're not liking that. So that's more lower in the respiratory center, and that's usually expiratory. And that's usually because of asthma or because there is some type of excess mucus or bronchospasm or the narrowing of the bronchus. Air can't get out, gets trapped. Don't like that sound either. There are lots of sounds that you can hear in breathing, but essentially what we're looking for across the room is a nice regular breathing pattern that seems to be within normal range, doesn't have any additional effort, doesn't have any additional noises. If you hear noises, you're going to act a little bit quicker. Circulation. How can I tell circulation from here, from across the room? Well, it's mostly to do with the colour of the patient. So if somebody's got poor circulation, if they're hypovolemic, they will essentially be pale. If they're in shock, they will essentially be pale. A lot of people, when they're seriously unwell, get kind of a grey pale. On the other hand, they might be a different colour. They might be red or pink. That can be to do with things like carbon monoxide poisoning. They might have rash. You might see that from across the room. They might be normal colour but have little blue lips. Cyanosis, not good. All right, so take in those visual clues of circulation from across the room. Disability. What we're thinking about here, first of all, their level of alertness. We're talking output and GCS. So from across the room, if I've said hi to them, what's your name? And they tell me their name back, I can assume that they're alert. If they don't tell me their name back, I'm thinking either they're shy, they don't like me, or there's something wrong. So I might try a different question, or I might get caregiver to say, go on, tell the nice lady your name, or whatever. If they can comprehend, they're alert. Sometimes they're a little bit sleepy. Hello, hiya, hello there. And then they open their eyes. Alert to a voice. Alert to pain. That might be just literally moving them or something like that. Some type of, not necessarily giving them pain, but stimulating them with touch. If they wake to that, pain response. Or unresponsive. You can do GCS if you want as well. However, as across the room, it's kind of difficult to do GCS. So I would probably stick to AVPU for an end of bed or a hands-off assessment. Other things that you can tell from disability are limbs. So are all four limbs moving? What is their muscle tone like? Can they sit up? Can they walk? Can they run away? Are they playing with toys? If you think about your adult patients, especially those who are having a stroke and are fast positive, they won't be moving all four limbs. Same with neurological event. You're not going to be doing any OBS in the hands-off assessment, so we'll leave some of the disability stuff to later. E, as you know, is either exposed or environment. If they're exposed, again, you're looking at them, you're looking at the colour, you're looking for rashes, you're looking for any type of trauma, those kind of things. If they're not exposed, we'll expose them later on when we put our hands. Sounds dodgy, you know what I mean. So let's look at the environment. What do you want to look at here? You want to be thinking about what's happened. If there's an accident or something like that, what could have caused it? Look around the room. Are there ashtrays? Are there alcohol bottles? Are there bottles of detergent that baby could have drunk? Or are there fighting siblings? Or is there broken glass? I don't know. Anything like that, you're looking around and looking for clues in the environment. This also comes into safeguarding as well. So when you're in the patient's house, if you're thinking, this is freezing, have you got any heating on, any problems with the heating, that kind of thing, you're thinking, is this living condition right for this child, or are they inadvertently being harmed because there is no money to pay for heating or electricity or whatever? That doesn't matter. It doesn't mean that you're calling social services on them. You're raising a welfare concern because people don't have the right living environment. That's another matter. You're going to have a whole lesson on safeguarding, so I don't want to go into that too much. But I want you to always have it in the back of your mind when you are with patients, such as pediatrics, who can't tell the story themselves. All right, sometimes they need us to do it for them. All right, let's move on. So here's another activity. So time for tea. Hopefully none of you smoke. I giving it all up for New Year, hopefully. So time for a cuppa or whatever you want, and wee biscuit to dunk maybe. Have a look at these guys and girls here. I want you to see what clues you could take if these were your patients. All right, I've written down 10 minutes, but pause the presentation, take as long as you need. Cheerio. Right, first kid here, impressions. She's probably airway breathing fine because she looks like she's making noises, probably laughing, gurgling, I don't know, screaming, talking at it, whatever the kiddies do. Her circulation, she might be a bit pale. She doesn't look pale to me, but I'll ask her mum. I'll say, is this how she normal looks? Sorry, I should say caregiver. It's not always your mum. So I'll ask caregiver, is this her normal colour, about the face? Yeah, probably. She looks happy, doesn't she? She looks like she's playing. She looks like she doesn't have a care in the world. On first impression, I am not worried about this child, this one here. I might change my mind when I start to do some obs or when I ask some history, but at the moment, not worried. Environment as well looks pretty clean. She's wearing nice clothes. She's got a laptop or a device or whatever it is. Yeah, she's probably happy enough. Right, let's move on to this little dude. Now, airway. Looks like he's got a good airway, but can't tell just from the picture. Breathing. I probably would take a whole minute to try and assess his breathing. He doesn't look like he's in good shape. He doesn't look like he isn't suffering from something or other. Circulation. Can you see his lips there? His lips are cyanosed. Not a good sign. This baby, kid, child, whatever you want to say, is in trouble. It's not good. So he might need some oxygen. Might look at getting the oxygen sats for him. Depending on the history of what's actually happened, we might provide different treatment. But at the moment, from my end of bed assessment, from my hands-off assessment, I think this kid's in trouble. So I'm not going to move on past B and C in the ABCDE. I'm going to go over it, step up, and I'm going to treat. Right, third one, this kid lying on the floor. Looks like he's got an airway. Looks like he's breathing. Might need to assess that. Might be noisy breathing. Circulation, I mean, he looks all right about the face. His fingers might be a little bit cyanosed. If it's trauma, I'd be thinking about the mechanism of injury. If someone's told me how he's ended up on the floor like that, I might be thinking about disability. Can he move all four limbs? Can he move his fingers? I might be thinking about a head injury. How alert is he? Looks okay, but what does he say when I say, what's your name and what happened? Is he going to tell me a full story, or is it going to be gobbledygook head injury? So, on first impression, I'm not worried to see him like that until I do an assessment. All right, this little ma'am down here, number 4, how does she look? Well, she's got tone. She's got her hands up, so I would assume that her airway and breathing are okay, but don't know without assessing. Colour, in terms of colour, I wouldn't be able to tell if this kid has got any cyanosis. What I would need to do, so in brown and black skin patients, you tend to look for cyanosis around the mucosa. So sorry, I wasn't just doing that randomly. That is the gum area. You can see cyanosis in the gum, in the tongue. Sometimes you can see it in the fingernails. Sometimes, as we've seen with the picture above, in the lips. But if you're not sure, have a little look in the gum. She looks upset. She might be tired. She might be not alert. First impressions, is she going to be able to be comforted? Or is this something more sinister? The last one, it's hard to tell with him. It's hard to tell with all of these without being able to assess the breathing. But on first impression, he's very guarded to his mum, isn't he? He doesn't want to go away from her, or the caregiver, I should say, sorry. Pale. I'd say probably a bit pale. Again, I'm going to look. Sorry, I'm not so sure if it's he or she. It doesn't matter anyway, but I'm going to look in the mucosa to see whether this patient is pale. In terms of their breathing, we can't tell from the picture, but something's up with them. They need comfort. They might be drowsy. If they're drowsy, that comes under disability. Patient's sleepier than normal. Patient doesn't look up when you call their name. For me, that's a bit of a warning sign. Now, as to what's wrong with them, that will come out on an assessment, but on first impression, I'm thinking this might be bad, this might not. So, not worried about the first one. I'm worried about the second one. I'm worried-ish about the fifth one. These two, the third and fourth, I can't tell yet. So sometimes your hands-off assessment doesn't give you all of the tools, but it gives you a general impression. I hope you find that useful. Next thing I want to talk about is the pediatric triangle. Sorry. Again, thirsty. Now, the pediatric triangle is how you assess a child from across the room as well, but it's in a more structured, logical order. Look at me doing a triangle. Oh, with that. Anyway. So this is used throughout your paramedic career. This is used by doctors, and as I said earlier on, it's recognized throughout the world. There are three elements. That's why it goes into a triangle. Instead of airway, we are looking at appearance, but essentially it's ABC. So let's put it in this order. You come into your patient, you're checking for danger, you're checking for the safety of the patient, bystanders, the relatives, yourself, your crewmate, etc. You're calling out, you're introducing yourself, you're gaining consent. When you do that, you expect a response back. When you get that response back, you'll know they have an airway, and you'll know they are responsive. On the AVPU scale, they are alert. Right, stop there. Then you move to the pediatric triangle if you're doing an assessment this way. So the first thing for me I like to look at is the work of breathing. But for you guys, because you're in first year, you might prefer an ABC approach. So let's do it that way. So A is for appearance. When I look at the child, what do they look like? So we have a mnemonic for that, which is tickles. Tickles is the tone, their interactiveness, the consolability, their look, and their speech. I am going to go through this again in a moment in the next slide, but this is just a snapshot of it. After appearance, I'm going to look at their breathing. In the pediatric triangle, we say work of breathing. So I'm not just interested in how their breathing's going, I'm interested in what effort does it take to breathe. That's a whole different thing. Okay, many of it will cross over, but the work of breathing is a lot more different than a breathing assessment. I hope you understand that. And the last part of the triangle is circulation to skin. So again, that's what we did previously when we did our primary survey, A, B, C, D, E. But the triangle is literally just these 3 points. So it's a very quick way to do your hands-off assessment. And it's not just quick and easy, it is pretty thorough, and it will flag up inconsistencies, red flags, problems with the pediatric triangle. So I popped a video on here. On the static one, you can click it. I've made it so you can click it. If you want to, you can pause the screen right now and you can just type that in. Or alternatively, I will get Scott to put this up as a separate link for you to click on. So it's ideal if you watch the video now. If you don't want it, that's cool. It won't matter too much. We'll carry on talking about the pediatric triangle. And after I finish with the pediatric triangle, that will be this chapter of pediatrics finished. The third part will be a completely different video. So if you prefer, you can watch the pediatric assessment triangle video after. I'll leave it up to you. All right, so appearance, tickles. What do I mean by this? So this is where I want you to get more involved. So if you were out on placement and you were assessing the child, instead of standing there and going, I'm checking the appearance, I'm checking for tickles. Right, that's tongue, interaction, consolability, look, and speech. No, that's not how it works. Let's do it properly. This isn't an exam, this is life. This is your job. Okay, so tongue. What do I mean by tongue? I mean, can the child sit up on their own if they're at the developmental age of being able to sit up on their own? Do they have the muscle tone to stay sitting or lying or whatever? A kid that doesn't, a kid that's really unwell, is floppy. You pick them up, arms dangle. All right, and I'm not talking drama. I'm talking literally they're not conscious enough to be able to move their arms, to keep that tone in their arms. They're flopping. So if a child's floppy, you're thinking that's a bad thing. Rigid, I've put in there as well. So muscles really tense. That can be a sign of seizure. That can be a sign of hypoxia. That can be a sign of various illnesses to indicate a child is very unwell. So we're looking at their tongue. If they're up and about and running around, tone's fine. If they're like, no, go away, tone's fine. All right, we're looking at the ones that are rigid or floppy. Right, tickles, eye, interaction. So what you're doing here is assessing how interactive the child is. So what that means is if they're not talking to you, no problem. Get the caregiver to talk to them. Are they interacting with the caregiver? Get Teddy to talk to them. All that kind of stuff. Do your glove balloon. Get the glove balloon to talk to them. Anything to see whether the child can be distracted and can interact with other things outside of you trying to assess them. So you are stimulating them. You are distracting them and see if they follow that distraction. If they're completely not interested, you're worried. Right? If they're not looking at mum walking around the room, you're worried. Right, that's interaction. Moving on, tickles. The C is consolability. So it might not be you that gets to console the child. I mean, it might be. Lucky you if you're that type of person that can pick up a child and make them stop crying. More often than not, it's going to be someone they're familiar with. So if the child's crying, we're already a little bit happy because they've got an airway, but at the same time, they're in pain, there's something wrong. We need to try and see whether we can soothe that or not. Sometimes it's, they don't feel well, they've got a sore head, or there's a stranger in the house and they might cry because of that. They're tired, they've got toothache, anything. They might be crying because of that. Quite often, if they're crying because of something like that, they can be consoled. So an example would be mum or anyone in this situation. Take the baby, cuddle them. Does that ease them? Does it soothe them a little bit? If so, great. If nothing, then you're worried. They're inconsolable. All right? Great. So moving on, tickles. L is look. Sometimes we say gaze or gaze in an English accent. So gaze and look is basically to do with what age the child is. So if it's a young child, they might not be looking at you properly. So look and gaze, what you do is you if you're moving around the room, or if there's a parent moving around the room, if Teddy's moving around the room, does the child follow with their eyes? Do they follow? Do they look around? Or do they stay gazing into the distance? Nothing is going to make this child look at what you're doing. So if they're concentrating and they can follow with their eyes, they're alert enough. That's okay. If they're not, they're nowhere. They are literally just gazing. I'm really worried. All right. And I don't want any of that kind of stuff. Just be like, over here, over here. See if they look at you even for a second. If they don't, like I say, you're worried. And last bit, speech/cry. So again, this is dependent on the age of the child. So it's comparable to what they would normally do. So if the child is at an age where they don't speak and they just cry or make noises, that's what you compare it to. That's why it's speech or cry. So are they behaving, vocalizing the way they normally would? So normal cry is a bit whiny, isn't it? It's a bit like however, that high-pitched cry, something's wrong. Or they not talking, something's wrong. Not speaking, no noise, something's seriously wrong. Children normally express their pain, their dissatisfaction with crying or moaning or whining or using some type of noise. When there's no noise or when there's extremes of noise, that's when you're taking it seriously and you're like, there's a problem here. All right, so first side of the triangle, the blue side, is appearance, tickles, tone, interaction, consolability, look, speech. All right, there's no K, there's no E, it's TICLS. Hope that's helpful, hope that's clear. Let's move on to the next side of the triangle, the green side, which is the work of breathing. So like I said previously, it's not just a breathing assessment, it's about how difficult, how much effort, I should say, and how difficult it is. So the usual things that we're checking are for breath sounds. We talked before about wheezing and stridor. Remember, wheezing is expiratory lower airway, stridor inspiratory upper airway. Bad news, stridor. Grunting, really bad news. So grunting, basically you're thinking about the nasal breather and you're thinking about the effort that the child has to have to breathe. It's like that. Their whole body has to project an energy to get a breath. That's a really, really bad sign. So hopefully you'll never see grunting, but if you do, let the alarm bells ring loud. Get that kid to hospital. Positioning. So we talked about tone. This is quite like the tone of that. So there's a lot more that can be detected from the way that a child is positioned. So I've put a few examples here. So sitting forward or tripod, both of those are respiratory conditions. What children and adults tend to do is get themselves into the most comfortable position that's going to ease their symptoms. If you've got difficulty in breathing, you're going to want to spread out so that your lungs can expand more. So sometimes they might be standing forward. Or tripod is literally 1, 2, and then your feet leaning forward like that. Or they might be just sitting forward. They might be curled up in a ball. It might be an abdominal complaint like appendicitis. You don't want to stretch with appendicitis. They might be lying flat because they don't want to move because their head hurts so much. Pay attention to what position the patient is in, especially if it's to do with their breathing. The breathing pattern, that's really important as well. So we know, like regular breathing, breathe in, 2, 3, hold, 2, 3, out, 2, 3, hold, 2, 3, or whatever way you've learned it. Anyway, if a patient has irregular breathing, something's up. If a patient has lots of gasping, something's up. If a patient goes fast and slow, I sound like I'm about to give birth, but I'm talking about pediatrics here. Thumbs up. Now, remember what I said before? If you don't know what these words are, pause me, Google them. It's okay. It's okay to Google things like this. You're not using it for an essay. So apnea, that means an absence of breathing. Dyspnea, that means difficulty in breathing. So we're noting anything like here. They have pauses where they stop breathing. Don't just assume it's a tantrum. Don't assume it's holding breath for attention. It might be respiratory. It's important to note that down, even if it does turn out to be emotional. All right, retractions. Now we talked about this earlier on. So that means when it's going inwards instead of outwards. So you might have sternal recession or intercostal recession. When they breathe in, it's being pulled inwards. That's a really bad sign. And this is a definite you've got to expose. So when we're doing pediatric triangle, it's hands off. But if you're seeing that, like sometimes the parents have already taken the clothes off, bad sign, recession. You're not happy with that. Okay, so the visible signs of respiratory illness, nasal flaring, really bad sign. Like I said earlier on, goes with grunting. Increased abdominal breathing. So I did say earlier on as well, if there's a little bit of abdominal movement, that's grand, no problem, because the diaphragm's a strong muscle there. But if all the breathing seems to be coming from the abdomen and their belly's going up and down, I'm worried. Why is it taking so much effort for this baby to breathe that their tummy has to get that involved in it? Something's not right. Head bobbing. This is one especially with the young babies. You're holding them, whatever. Every time they breathe, they're like, uh, 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 because their whole body is trying to move to get that breath in. That's a really bad sign as well. If you see these, trust your instinct. Say to your mentor, that child's head bobbing. That child's got nasal flaring. Look at the abdominal breathing. Look at that retraction in their chest or in their intercostals or whatever. Point it out. Please don't stay silent, because these are late signs and bad signs. And the final late sign, the worst, when they get too tired. This is pre-arrest. Have you heard the term peri-arrest? Peri-arrest means they're about to arrest. And you know now that most pediatric cardiac arrests are respiratory or oxygen related. If you have a patient that's getting way too tired to breathe, they're minutes from cardiac arrest. And you know you're probably not going to be able to shock them. So it's going to be really quite difficult to reverse the cardiac arrest. So please trust your instincts. I'm really sorry I keep repeating that, but I can't say it enough. Something is wrong. Tell somebody. Do something. Getting all worked up. I need a drink now. Right, next, circulation. Circulation to skin. So that's the red part of the triangle, the final part of the triangle. So we talked earlier on about circulation when we did the hands off. When you're in the pediatric triangle, we're talking about any circulation that we can see to the skin. So have a look at the skin color. Is pale? Is it mottled? Mottled. What mottled means is basically you have like purpley white patches all over, and that might be to do with an illness or infection. It might be to do with heat. It might be to do with coldness, temperature. So mottled skin needs further investigation, as do all of these. Cyanosis is normally hypoxia or circulation. Red, like I said before, rosy red can be carbon dioxide. Grey sometimes comes with peri-arrest as well. So if you're not sure if the child is pale or a different color than usual, don't be afraid. It's not rude to say to the parent or caregiver, is the child's skin complexion the same color as it normally is? That's not rude. Some people might take it the wrong way, but it's a genuine question. Were they in the same skin color yesterday? Do they look a little bit pale? All right. Any type of rashes. The main rashes you'll see out there, chickenpox, measles. I have an activity about rashes a little bit later on, so hopefully you get to know more of the presentation. But what I need you to know today are the sinister meningitis rashes. Now, most of you already know about meningitis because it's a uni thing, isn't it? Young people who are congregated together quite often are at risk of getting meningitis, particularly viral, but it's bacterial meningitis which is the killer. And that will kill 10% of people that have it. So it's really important that we find meningitis rash. So at the moment, we're hands off, we're doing our pediatric triangle. It's enough to say, oh, I see a purple rash on the skin. You're going to investigate that further when you touch the patient with the glass test. But for now, you're saying circulation of the skin is dodgy. There is a rash. Lastly, have a little peep at their extremities, their fingers, their toes. Are they cyanosed? Their lips, end of their nose, ears. It can be Like I said, it can be hypoxia, it can be poor circulation, it can be blood loss, it can be shock. So anytime you see little tiny little fingers like that one down there, that's a red flag. That's something that you don't want to be seeing. All right, so 3 elements of the pediatric triangle, are appearance, tickles, work of breathing, circulation to skin. Tickles, tone, interaction, consolability, look/gaze, speech/cry. Hands off, and then next bit we are going to delve into the assessment. All right, we've done loads already, and all we're doing is looking at the child. You can see how important this is. All right, I'll sign off now. I'll see you in part 3.